Hi, and welcome to Cornetti and Craft sponsored webinar on the Home Health Survey Alert around COVID-19 activities. I'm your host today, Dee Cornetti with Cornetti and Craft, and we have Cindy Craft joining us monitoring our Q&A box, and we have four guest speakers today. First, Arlene is a registered nurse and home health and hospice consultant who is certified in compliance with the HCSC credential. She is the owner of AD Maxim Holdings, LLC. She's a frequently sought after speaker for patient quality care, analysis, and administrative functions in the post-acute healthcare world. Arlene serves as a board member and vice chair for the Association of Home Care and Hospice Coding and Compliance in Gaithersburg, Maryland. Her current focus of public speaking, training, and consulting include, but are not limited to, newly released conditions of participation, face-to-face strategies, PDGM, RCD, STARS rating in home care and hospice, functional improvements in patients in the home, with the reduction of hospitalization and other significant changes that we could expect in the near future. Arlene currently leads innovative changes across the healthcare continuum through her many years as a consultant. She has developed and implemented multiple post-acute care programs, working closely with multiple hospitals, home care and hospice agencies, and accountable care organizations. We also have with us today Sharon Harder. Sharon is the president of C3 Advisors, LLC, located in Chicago. C3 specializes in home care and hospice compliance matters. Sharon is a frequent speaker and author and has been authoring a series of weekly COVID-19 briefings designed to keep post-acute providers up to date through a single resource dedicated to their COVID-19 information needs. In tamer times, she focuses on compliance audits for C3's clients, due diligence related to acquisitions, and assisting clients with investigations and documentation requests. She is a frequent speaker and author of white papers, alerts, and articles about topics of importance to the industry, and is also an Association for Home Care and Hospice Coding and Compliance board member. Lori Apple is the president of Corso Care. She is currently responsible for setting clinical direction, overseeing operations of Corso Care, and leading healthcare strategies for Common Sale. Corso Care is a certified home health care and hospice company. With 32 years of nursing experience, she previously co-founded a regional multi-million-dollar Medicare certified home health care company. Early in her nursing career, she combined her clinical knowledge with her legal interests and began working as a specialized member of a litigation team that led to earning her certified legal nurse consulting credentials. Her working career included clinical, operations management, risk management, and providing strategies for organic growth and acquisition. She's currently licensed as a practicing nurse in Michigan, Florida, and is also an active board member for the Association of Home Care Coding and Compliance. And finally, we have Robert Marquette with Hall Render, Killian Heath, and Lyman. Bob, in over 15 years, has focused his practice on representing home health, hospice, private duty, and DME providers in all aspects of their operations. With more than a decade of experience in working with these industries, Bob has developed a reputation for understanding the operational, compliance, and legal regulatory issues facing home care providers. In representing the home care industry, Bob has assisted clients in a number of areas related to their operations of business. He works with his clients on issues related to Medicare, Medicaid compliance, including surveys, responding to surveys, state and federal appeals of survey findings, payer issues, including appealing payer audit findings, HIPAA compliance, Medicare and Medicaid fraud and abuse, including matters such as developing and implementing compliance programs, performing internal investigations, and representing providers in external investigations and civil and criminal matters. Bob also assists clients with purchasing and selling home care, hospice, and private duty agencies. And so without further ado, I'd like to welcome all the panelists here today, and let's get started. Today, we hope that you will walk away with the ability to identify key focus areas specific to surveying activities related to COVID-19, review and prepare necessary materials in advance of COVID-19 specific survey activities, if you haven't already, and discuss impact of immediate jeopardy, or IJ, related to COVID-19 specific survey activities. But first, a couple of housekeeping tasks. We do have a Q&A box that is available to everybody on the live webinar. So please, throughout the session, if any questions come up, don't feel the need to hold them till the end. Please feel free to type any of those questions you have regarding today's program in the Q&A, not the chat box. Cindy Kraft will be monitoring these. We have allowed time at the end of the presentation for Q&A. We are also recording this session, and you as a signed-in provider will receive a recorded link to this webinar. However, if you are listening to it for the first time in the recorded version, you may ask questions by using the email addresses provided for all of the speakers that is available at the final slide in this presentation. And so without further ado, I'd like to introduce Sharon Harder with C3 Advisors, and she's going to kick us off with Survey Alert Introduction. Sharon?
Thanks, Dee. Well, welcome everyone. So it's an interesting time that we live in, and about a week ago, with our collective ears to the ground, Dee, Lori, Arlene, Bob, and I all began to simultaneously hear rumblings from the field about an uptick in focused surveys aimed at gauging infection control efforts and emergency preparedness. Now, all of us knew about the guidance that had previously come out from CMS, that March 10th QSO, I believe it was QSO 2018, and its follow-up cousin, QSO 2020, that was released a couple of weeks later with news about how CMS was going to reprioritize state survey efforts away from standard surveys and toward focus surveys on infection control. Now, I can't speak for everybody else, but at the time that I read that last memo, somewhere in my brain, it registered that this could be an issue for home health at some point, but that it was probably much more directed at other post-acute care venues, and in particular, skilled nursing facilities. However, alas, I was wrong. The surveyors like to visit home health agencies apparently almost as much as they like SNFs these days. And so we are now getting their attention, especially as more people are discharged from hospitals to recover from COVID-19 at home. Now, in that March 23rd memo, CMS indicated that it would exercise enforcement discretion for a period of 3 weeks. And of course, those 3 weeks are long gone now. In that memo, CMS also said that it would prioritize complaint surveys and facility reported incidents right along with infection control, which now seems to be the tip of the spear. Next slide, please. So back to QSO 2020, and I think that's one of your handouts this afternoon. Toward the back, you're going to find a focus checklist for acute and continuing care with several categories of survey items. Now, the whole memo is worth reading, but the gist of it is this. While infection control is the phrase of the day, if surveyors find other things to complain about, then they are free to do so. Now, I'll be honest, I've heard from a couple of home health agencies, one of which did get some citations as they moved into a full survey, and that didn't surprise me a bit. The other one did not have any problems at all based on the lengthy conversation that we had together. So for the most part, I think these seem to be focused on remote exercises that remain fairly narrowly defined, and most agencies appear to be emerging without major injury as long as they've been attentive to the COPs around emergency preparedness, disaster planning, infectious disease threats, and sort of integrating that into the emergency prep plan, which needed to happen last year, infection control, and transmission prevention. One thing that some agencies are running into, though, is the application of Appendix Z. And that's where all of those emergency prep rules are. That was updated last year to add infectious disease as a required category of hazard assessment. And again, this year, it was updated to establish that 2-year update requirement for the plan and policies that go along with the emergency prep program. Next slide. So here are a handful of things that agencies really need to be cognizant of in terms of these surveys. So make sure that as you're thinking about this, you have your act together on these 7 things. And of course, Lori and Arlene and Bob are going to talk a lot more about this. Do the self-assessment exercise that is outlined in that March 23rd QSO 2020. Make sure that your infection control policies are updated and that they include a reasonable surveillance plan along with policies that are specific to COVID-19. Make sure your emergency preparedness plan is updated and that the policies are comprehensive. Make sure you have procedures in place for staff and visitor screening at the office. If it's open, if it's not open, make sure you have signage that tells the visitor what the scoop is and how to reach you. And also make sure that you can demonstrate attention to things like training around hand hygiene, staff screening, the use of PPE, all of the recent education that's occurred on these fronts. Next slide. So these surveys are not limited to specific areas. Everyone needs to be prepared no matter where you live. Most of the states that are listed on this slide have fairly significant outbreaks of COVID-19 right now, and I'm guessing that's why they were first and why we've heard more from agencies in these states. But make no mistake about it, the surveyors are going to get around to everyone at some point. So that's the 30,000-foot view. Arlene and Lori are going to walk us through some of the details of what you need to know and need to be doing right now. So with that, I will yield the floor.
Okay, thank you, Sharon. It's Arlene Maxim, and I'm going to start off talking about what we need to do to tackle these infection control surveys. Sharon already covered the March 4th and March 20th memos that came out from CMS. I've given you here the actual guidance for immediate jeopardy in Appendix Q. If you don't have that already, I would highly recommend that you not only read the memo, but also read and understand Appendix Q regarding immediate jeopardy. Lori and I, as we go through this, we're going to cover some things on a surface level. Bob's going to go do a deep dive on almost everything that is going to be important during this webinar. So how will the Focus Infection Control Survey be completed? Sharon touched on this a bit. Most of the surveys are being done remotely. Sometimes what I've heard that sometimes the surveys are done partially remotely and then the rest of it on site. One of the things that you need to understand and make sure that your surveyors are covered with is the protective equipment. They're supposed to be using the same guidelines as we need to use when we're in contact with others. So while this is encouraged by state and CMS surveys, the accrediting bodies are probably going to follow suit. They're hoping that they will. So if you're accredited, your accrediting body may come in to do some of these surveys, but otherwise you may see a state surveyor show up at your door. So what if your infection control survey goes wrong? This is a potential problem. I did have an agency in the last couple of weeks that had one of these surveys, and it didn't go as well as they would have liked it to have gone. But like Sharon said, if the surveyors see any kind of concern whatsoever, they can go into a more focused survey into other things. So it's not going to necessarily be limited to just infection control and emergency preparedness. So be sure that you have everything covered that we're giving you guidance on today. This is another resource for you, Appendix Z, that's going to cover the emergency preparedness program that CMS expects you to be following. Again, on April 23rd, just a couple weeks ago, CMS issued the most recent guidance on these surveys and indicated they would be coming to the agencies or doing remote surveys with potential to confirm, offering support for agencies addressing potential and confirmed COVID cases. It's not necessary that you have a COVID case on your roster. Some of the agencies, in fact, I had one agency that had only one patient, and that was not a COVID patient. So it doesn't mean that just because you have a COVID patient on your roster that was the only time that they would be visiting you. Okay, the next slide, Dee. Okay. Tackling targeted infection surveys, making sure that you're always ready for this type of survey. We've preached, all of us have preached for many years that you always have to be ready. You never know when a complaint survey is going to happen. This particular type of survey, we've had limited notice. Some agencies did not read the memo, and so it was important that you all understand that you always need to be ready. Even though they tell us that they're putting the routine surveys on hold, it does not mean that they won't come to your agency to do a focus survey such as this. So the things that we're can you go back, Dee, just a minute, please? Can you go back one slide? Thank you. The things that we're recommending for preparation would be to make sure that you have a dedicated work group, folks in your organization that can pull things together for you. And I know many of you are working remotely now, so some of this is going to have to be done virtually, but make sure you have your policies and procedures together. You have policies and procedures for your PPE. That's a struggle for some agencies. And if it is a struggle for you, you have to make sure that you identify what you're going to do in place of the formal PPE that's required with the masks and the gowns and that type of thing. Look at your staffing plans. They may ask you about that. And then make sure that you're preparing for post-recovery plan. We should be going into that pretty quickly within the next month. So make sure you have some plans for that. With that, Lori, I'm going to go ahead and turn this over to you for the remainder of our section.
Thanks, Arlene. Today, really excited to talk about this topic because it impacts all of us. And I think my colleagues have mentioned that at some point this will definitely impact all of us. In Michigan, we're seeing it pretty prevalent. I also oversee a skilled nursing facility in Iowa, and it's definitely prevalent in Iowa. That wasn't one of the states listed, but I know that there have been many infection control surveys being done there. When we start to talk about this, what the surveyors will be reviewing, Arlene touched on choosing a team, and I can't stress enough the importance of that. I feel like we're all just hitting our stride now. In the beginning, everybody scrambled. How do you work remote? I mean, it's certainly not an industry that we're accustomed to working remote in. And when you kind of get through the bumps and bruises of that, and you start to hit your stride, you realize you really need a great team, and that's what's going to pull it all together. In terms of at Corso Care, excellent administrator, excellent director of QAPI for corporate QAPI and compliance. I mean, that's really what it's all about. And then when you look around you, it's not just them. Who's missing? You're looking at the entire team from who's helping you with your IT and your applications and all that to help your clinicians get through. They're already struggling and frustrated. So when you're preparing for this, I just want to touch again on that team portion. So what will the surveyors be reviewing? We're looking at the emergency preparedness plan right out of the chute, obviously, infection control policies and procedures, your infection control logs, information related to any COVID positive or presumptive positive patients, along with information related to any COVID or presumptive clinicians, um, clinical record documentation, personnel files, infection control in services, any additional documents necessary to comply with state requirements depending on where the survey takes place. I'm going to just go through and break down just some of this as I mentioned, the excellence in terms of who's directing your QAPI, your compliance, your infection control. I'm very fortunate in the folks that we have um, at our organization. And some of the things that we've talked about is the fact that the infection control manual for 2020 in preparation for this has all been reviewed and updated. As part of this process, infection control risk assessment reviewed, updated. Reportable diseases in Michigan with the 2020 guide, updated the directory of Michigan Health Department 2020 information. Working with your regions and your emergency coalitions and housing those logs and initiatives with your meeting minutes, proof of working through the coalition to work with FEMA. So you not only have state, but you also have federal influence. Getting ready for any survey is unnerving. I mean, everybody, that like, think about when we just know it's coming, right? Oh, we're in our 9-month window. Okay, we're in our 6-month window. Well, especially with clinicians and administrative staff working remotely during this pandemic, that makes it even more nerve-wracking. It would be advisable to make preparation for this survey a priority. Sit down with your executive team and just say, we're going to just run through this A to Z, make sure with the checklist, what are you ready for, what you're not ready for, and then have someone accountable to each one of those and be revisiting it. I say I like to revisit it. When we have a checklist and we're preparing for something, we revisit it daily until it's complete. So gather your team, include your clinical team, let them help develop a plan. I'm sure you have key players. And then, of course, be certain to post that notice on your organization entrance, providing a name, phone number of each person to reach when the office is closed during the hours of operation. With the pandemic, many folks are working remote and just going in. We open 2 days a week and do curbside service for our clinicians to receive PPE. And so when we're not there, if a surveyor shows up, they certainly need to know how to reach us. Can you just advance the slide for me, Dee? Thank you. So the other things that in a typical survey, you'd need to have ready your patient census, current unduplicated 12 months. Whoever is doing that for you, if you get your biller involved, make sure that they're, that it's going to be a quick and easy process. I can tell you that in one of the places that I oversee in the skilled nursing facility, they actually said, hey, upon entrance, here's what we want. And then within 1 hour of entrance, here's the additional documents. So it was very organized and broke down exactly what they wanted. But the organizational chart, the copy of the license, if you're in a state that's licensed, Michigan is not licensed, is not a state that has oversight for licensure. Copy of your CLIA, complaint logs. Go ahead and advance, Dee. So in terms of the infection control and the emergency plan policies and procedures, we ran through some of the things. Be sure that they're updated, obviously, with COVID-19 precautions. Update your local emergency response operations and be certain to include patient classification levels to assist with triage if necessary. Our administrators run through that and look through that daily so that we can triage where our patients lie, who needs immediate care. The more information, I like to say, the more information you can provide in an organized manner and you can articulate your process, the more comfortable the surveyor is right up front. If you've got your information organized in a binder, meeting minutes, and you obviously know the process, it's amazing how just having that will not have people go, there's not a great need. Many times they won't go really deep. If you don't have those things and you're not organized, that's when it starts, when I think Arlene said, what if the survey goes wrong? That's I feel like when folks start looking a little bit deeper. Patient education examples of teaching materials, have those ready and housed, so that you can just show, hey, here's our in-services, here's our minutes, here's our logs, here's examples of what we taught. Um, and having that ready for the surveyor makes all the difference in the world. Um, be prepared to articulate how you identify and report COVID, in terms of your infection control and your infection control logs. Be sure that these are updated and any diagnosed COVID-19 patients or employees are listed. The logs need to be accessible for review by the surveyor, and be prepared to discuss how you operationalize your first person exposure. And when it comes to identifying first person exposure and any of the things that you have questions on, us, for example, we utilize Michigan Department of Health and Human Services, WHO, CDC, JCA, and CMS. We also keep, which we find very important, again, to keep us organized. And I'm sure for all of you like us, when this first started, every day things changed, and they changed sometimes within hours, right? So our team was very organized when they took all bulletins and executive orders. They kept all of those in chronological orders and binders. Um, for all inspection control and emergency prep, for the pandemic policy to update and include the COVID updated and reviewed spreadsheets. All of that kept in binders so that we could just refer back to that specific date and say, hey, here was what we learned today, and here was how we answered it. Contract companies and memorandums of understanding for surge, be organized. Just that, I guess that is what I'd like all of you to take away. Get yourself and your executive team set up and organized, and be able to articulate why you made the decisions when you made them. And maybe many of us had to make decisions based on our availability to access PPE. Um, Next slide, Dee. Thank you. So in-service records. Be sure you have staff training for COVID-19 with indications of all the precautions being taken during this pandemic. For example, careful review of bag and proper hand washing techniques, assuring availability and instruction on appropriate use of PPE, include all your attendance signature logs, and be prepared to illustrate how you educate and manage on PPE. I know that we did multiple in-services when it came to getting our employees ready in answer to this, for standard precautions, again, including contact, droplet, airborne, all of that was reviewed. Of course, PPE policies were reviewed. I was speaking to a physician the other day, and we talked about the buddy system. If you can use a buddy system for donning and doffing. For us, that was hospital, right? For us, we're doing that in the home. And there's nothing more important than making sure that you're donning and doffing your PPE correctly. Because all the PPE in the world will not protect you if you have not been in service and educated properly on how to use it. Okay, next slide. Thank you. Personnel files. So have all the personnel files up to date. This is a really big thing. This is what I've been hearing in terms of PTO policies, FMLA policies, and staffing backup plans specific to each position. When it comes to that focus on HR for FMLA, short-term disability, LOAs, you need to prove that you're offering your employees appropriate options. And that's going to be the big thing that folks look for. Through this, Certainly, we wanted to keep as many people working as we could, but then there's other folks that just can't work through for whatever reason, whether it be they have a chronic illness themselves and they've presented with a physician note. And we want to make sure that we're prepared to show how we dealt with that along with any staffing crises. All set for the next slide, Dee. So in summary, in addition to infection prevention and control, some agencies are reporting that certain surveyors are asking about an organization's use of telehealth. So telehealth, whether it be, telephonic, because many of us patients don't have access to the telehealth other than telephonic. So telehealth documentation and our one big question that comes up often, are telehealth visits being billed in place of an in-person visit with patients? So no, you cannot bill telehealth visits in place of an in-person visit. What you can do is make sure that you're giving that patient the appropriate care that they need. And on top of that, if you feel that they need additional screening, I recommend that you work through your system, whether, whatever documentation system you're using, as we did, and we made that's incorporated in so that when we do telehealth visits, we still have the ability to document that we've had oversight, but those are non-billable visits. Next slide. So the other thing that the surveyors are going to be looking at when they come in is they want to visualize how is your office staffed to ensure employee safety. That's going to be, I think, just an ongoing, that's not going to go away today or tomorrow or, whenever we have a stay at home safe order here, and it's going to be lifted soon, I'm sure, but there'll still be that need for social distancing. So for them to be able to visualize the changes you've made in keeping your staff and safe in your work environment, and how you're practicing the social distancing, the agency pre-screening employees for safety in the workplace. What happens the minute you walk through the door? What happens the minute we walk through the door? There's screening questions, taking a temperature, making sure that you're putting your mask on. So what screening process is being used not only by us for the folks in the office, but also what screening process is being used by the staff for the patients. And be prepared, because I have heard many surveyors are calling patients and nurses to verify this education, verify the screening process, and the old trust but verify. So that's where we're at right now. And with that, I'm going to hand it off to Bob Marquette, and he will go into all of the deep dive on the legal aspect of everything we've talked about. So off to you, Bob.
Thank you, Lori. So I will kick in now. Everyone loves to hear from the lawyer. And my job is, in part, I think, with the IJ process to frighten us all a bit, because as Sharon pointed out at the beginning, I think we all got a little bit, we didn't get lax. We haven't had time to be lax. We've been too busy trying to keep up with all the change. But we haven't thought about surveys. And I think as Lori and Arlene and Sharon have all said, that early guidance that came out, what seems like a lifetime ago, but in reality, it's only been 6 weeks ago, led us to think that CMS and the states recognized we had bigger fish to fry than the surveys. However, I guess the surveyors are bored. Probably this, I think, is coming from CMS. They've decided it's time to check. And Sharon, I think, is correct. They are wanting to check because they're seeing issues. This started in nursing homes and the COVID in the nursing homes, but they're checking elsewhere to make sure we're not part of the problem. And so infection control surveys have begun, and that's really what this is about. This is about infection control. I think that we kind of made that one clear so far, and you need to be ready. And Arlene and Lori did a really good job of talking about being prepared and stuff you want to have ready, because they're coming. They might call, it might be remote. We've seen them go both ways, depending on a number of factors. But if they come to you for a survey, they're going to be looking, and if you've ever, as we're familiar with surveys, they don't generally grade on a curve, and the infection control stuff is very serious for them. And we've talked about some things they're going to look at. You know, if they do field visits, and I don't know if they will or if they have, but it sounds like from what we're hearing, some surveys may even look like more traditional surveys with the surveyor coming out and observing. And infection control was an issue before. I know, I've done presentations with all of my co-presenters today in another context, and at some point I think I presented about surveys with all of them, and infection control has always been an issue. It's always been something that surveyors have looked for and focused on. And I can't think of the number of times in the last year I've seen an agency get cited at a condition level just for hand washing and those kinds of failures. So they're going to look at those kinds of things. We have been inundated, even if you're not in healthcare, with hand washing. And the example that I use is right before this all happened, I was in San Antonio at a health law conference. And I remember commenting to my wife on the flight back, because this is early March and people are starting to get concerned and become more aware of viruses and how viruses spread and things like that. And the big tell for me that something was different was being at the airport, coming out of the restroom and seeing the line at the sinks. People were actually stopping to wash their hands and using hand sanitizer, and you saw that much more frequently. So now everyone's aware of that. So you know that that's something that surveyors who are already focused on it are going to be thinking about. Use of PPP, I said this to a number of people back when this started. We have enough trouble with staff properly washing their hands and using barriers. When you read the CDC guidance and donning and doffing, and there's actually videos at the CDC's website, and I believe also at OSHA's website, that demonstrate the proper techniques for healthcare workers to don and doff personal protective equipment. Although I used PPP in my slide because there's a whole separate triple P acronym for the Peril Protection Program. But the personal protective equipment isn't as simple as washing your hands. And so I said to co people, if they survey on this, I can see that being a real issue. If they come out to watch what your aides and your nurses do, are they doing it properly as they come in out of the home? Barriers, patient education, and then staff education and complaints. One of the things I've dealt with a lot in the last couple of weeks is the staff not wanting to serve COVID patients, not wanting to go into the field, or staff who realize they can make more money on unemployment than working. And so these staff education issues try to get the staff okay with going into the home and serving the patients, educating patients about COVID and things like that. These are all things that I think are important for the survey process. And when they come out and look at it, if they want to, they can go beyond that. And Arlene talked about them expanding beyond just the infection control. From there, they can look at all sorts of things. It seems to me pretty certain if they find infection control problems, it's going to be a condition, and it may be an immediate jeopardy. If you have paid attention to Appendix Q and how they changed it last year, it's much easier for them to call immediate jeopardy now. It's a much more subjective process, and so I anticipate we'll see more IJs coming out of this. And an IJ is significant. The immediate jeopardy process is a 23-day termination process. Now, they're not supposed to use it just to get your attention to make you move faster. They're supposed to use it when there's actual patient harm. Well, not actually, when there's a concern there could be patient harm. There doesn't have to be patient harm. In fact, if you look at the guidance in the operation in the Staff Operations Manual Appendix Q, it talks about it has to be an immediate threat in the surveyor's mind, but the surveyor doesn't actually have to articulate what that immediate threat is or when it might come to pass, which doesn't seem like an immediate threat. So we have this very open-ended standard. We have COVID, which has become something about which CMS is very concerned, and we have infection control, which is the means by which they want to stop it and bend the curve. So I do believe this immediate jeopardy is a real concern. If you're found to have caused an IJ, you're going to have to respond quickly because of this 23-day termination track. So the way the IJ process works, and I'm going to go through this a little bit because we saw an uptick in IJs last year, but I don't think everyone's really familiar with how the IJ process works. If they find an IJ, they must immediately notify the administrator. There's an IJ template form, you can find in Appendix Q, that they're supposed to use. It's a written document, it's a one-pager, they write it out by hand, and they have to give that to you. They're supposed to do it in person. They should not, there are rare exceptions, but generally they're not supposed to leave and call you later and tell you it's an IJ. When they're there, they should tell you. Sometimes I have seen they tell the agent there's actually a chance to get the IJ addressed while the surveyor is still there. They don't have to do that, but they should not leave without telling you there's an IJ. You will get the IJ survey reports later. It will only include the IJ tags. Understand, when they tell you you have an IJ, they will tell you what tags support the IJ concern. They're not going to tell you about the other tags. You're only going to learn about these. So don't think that's the only issue. You then have to prepare a plan of removal. This is a quote out of Appendix Q. Unlike a plan of correction, the plan of removal is not necessary. It doesn't have to remove the complete, or correct completely the conditional deficiency. It has to remove the noncompliance to the IJ so that the issue of harm is gone, even though the condition might still be there. So the plan of removal, your goal is to demonstrate the systemic problem the surveyor thinks that they've identified that could cause patient harm has been removed and the patients will not be harmed. So then the state agency has to approve the plan of removal. The goal here is to get the plan approved on the first try. I have had cases where we have multiple submissions before the plan gets approved, and that wastes time. You have 23 days to get this right. You can't afford to not get your plan of removal done correctly right out of the gate. Once it's approved, you implement it. Once it's done with implementation, you will be resurveyed to determine if the IJ has been removed. And again, a quote from the Staff Operations Manual, they consider the IJ to be removed when the surveyors verify you fully implemented the plan and no recipient is currently experiencing serious injury, serious harm, or serious impairment and or a risk thereof. If it's not fully implemented, the IJ continues until the removal plan is fully implemented and the likelihood no longer exists. If the IJ is lifted, that does not mean that you're fully in compliance. At that point, they would then issue the complete 2567 and request a plan of correction aimed at substantial compliance. At this point, the IJ rescinded, you'll be off the 23-day termination track, but you will still be on the enforcement track. It's important to note, an IJ can come with penalties, with daily civil penalties that are quite steep. When the IJ is removed, those penalties may continue, but be reduced. If you recall how the civil penalties work, they're tiered. There's a higher tier for IJs, so if the IJ is lifted, they can reduce those fines, but leave them in place for the condition of noncompliance. You're then back to the more normal termination track, submit your plan of removal, your plan of correction, implement it, and they take you off the termination track. But you've got to clear that first 23 days. 23 days is very time compressed, and it's very pressure filled because you're looking at a short term, a little over 3-week termination. You require an intense amount of resources to respond to it because that's going to be your focus. IJs are difficult to deal with in good times when things are relatively normal. In the midst of this pandemic, where we already have so many other issues, an IJ is going to be very difficult. Staff will likely working remotely. And so you're going to try to get these folks together to prepare and implement a plan of removal while on WebEx or whatever. You've got to get things rolled out. You've got to do education and in-services on whatever it is that's going on, potentially for all of your staff, while trying to maintain social distancing and all these other things. It's going to be very difficult. And then when it comes time for them to resurvey or for you to verify, if you want to make sure your staff are doing things right, many of us are facing challenges getting into patients' homes. Well, if I've retrained my staff as part of a 23-day IJ, I've then got to get out and make sure they're doing it correctly, just in case the surveyor wants to. Then I've got to find some patients that'll let me come into the home and do all these things. It's going to make life more difficult. So you really kind of hammer home Lori and Arlene's point. You really want to be ready when the surveyors show up so that you can avoid all of this. Something else that's kind of something I think you need to consider, and Lori and Arlene touched on this a bit during their presentation, your staff and your preparation of the survey process. And Lori and Arlene covered a lot about the things you want to be ready with, policies, procedures. A couple of other things to think about. the signs posted prominently, Lori mentioned, I put it in there as well, because you don't want the surveyor to show up, knock on the door, lights are off. They may assume you're operating remotely, but in Indiana, the state survey agency put out guidance that said you need to have clearly posted signs so they can reach you or others. Because at the time they sent that, we weren't expecting surveys. We were thinking more random patients, et cetera. So be sure those signs are up. Be sure they're staying up. If you don't have people in the office, you might want to go and check. Bad weather, people who are out bored, but whatever it might be, those signs come down, you can have a problem. And if the surveyor comes in the office, if you're in the office and they come in, Lori and Arlene talked a lot about social distancing in the office and things like that. And I think that may be, as we start to return to normal, kind of the new normal. We just got an email at work. We're a law firm. We're just in a regular office downtown here in Indianapolis. But next week, what we're anticipating, the governor is going to open up things here shortly. But our building said, look, if you come into the building, you need to wear a mask. So those policy procedures you have, the surveyors need to be treated the same way. Arlene and Sharon both mentioned that the surveyors don't seem to be coming out in person if they don't have personal protective equipment. So that's good. If they come, they should have it. You shouldn't have to provide them with personal protective equipment. But then you treat them the same. If I have a policy on screening before I come in the office, I would think you would take the surveyor's temperature as well. Ask them for symptoms. They're not above this. They're just as susceptible to COVID as anybody else. And I had a client that actually had COVID in their offices. The field staff, because they made a decision at the very beginning, the field staff would never come to the office anymore. They were doing it remotely. 60% of their office staff got COVID. So we're going to treat the surveyors the same. Another distancing issue. If the survey goes beyond infection control, if they start looking at records, if they wanted to access your EMR, we would normally give them a tablet or a computer. Well, part of our issue with EMR is usually having somebody sit with the surveyor to help them navigate your EMR, because EMRs are different. They don't know your EMR. But how do I help the surveyor with EMR while maintaining social distance? How do I work that? Do I have some way to remote in? I've got someone across the room. After they're done, how do I disinfect the tablet and the laptop? And don't think for a second, because you're helping the surveyor or working the surveyor, they wouldn't use that against you later. And then the surveys occur remotely. There's questions there as well about how do we know who we're dealing, how are we talking to people? How do we get them documents? And then we talked about patients. Oh, thank you. Okay. We tell the surveyor wanting to talk to your staff and your patients. I have for several years now had a general objection to surveyors contacting our patients and surveyors outside of our chain of command. Because they don't like to do it because they think we're trying to control things. However, here's the question. How does your patient know when a surveyor shows up at their door unannounced with no contact from us, or when they call, that they're actually talking to a surveyor? How does a surveyor know, a nurse or a staff member know when the surveyor calls and it's a surveyor? I felt for a long time it's a HIPAA issue. Now, I think there are other issues, because there are a number of schemes out there already where people are trying to take advantage of folks through COVID, et cetera. And we would really hate for our patients to be taken advantage of because they think they're talking to a surveyor otherwise, and they share information they shouldn't. It's also an infection control issue. How can I know the surveyor is following my policies if they go out to see a patient, or if they intercept? And I've had surveyors just show up at patients' homes as our staff walks up. That may be not a normal protocol, but for this environment, it's a patient rights issue and an infection control issue. It's also much less stressful to staff if things go through me. If I'm an agency and I make the state contact me, and then I contact the patient, I contact the staff member and arrange the interview, it's less stressful. And it's a bigger issue with our patients now. Right now, our patients are afraid. A lot of our patients are refusing care. They're refusing to have our staff come into the home for fear that we might give them something. When a random surveyor attempts to visit, it's going to be the same issue. So we have to call. And it's more likely now than it used to be, I think, that a patient would decline such a visit. But I think it's important for the surveyor to understand that they need to go through us so we can at least reach out and talk to the patients because of these concerns the patients have about COVID. And so as we continue, some additional wrinkles we have because of this, we're doing fewer in-person visits. That means there's fewer opportunities if a surveyor wanted to go to the home, wanted to see a patient, to go out. When we talk about patients wanting some but not all staff, much wider use of telecommunications, and that's been something we've been moving towards anyways, but now, in light of the telehealth expansion, which doesn't allow us to do billable visits that way, but it's making it easier for us to do things like supplement our normal billable visits with telecommunications, two-way audio, video, et cetera. But that means it's harder to arrange visits. If I'm doing, based on interim final rule, the LUPA number of visits and then supplementing through the plan of care, probably documented, et cetera, with telecommunications and remote monitoring with objective goals, I may have far fewer in-person visits the surveyor can make. I'm not doing supervisory visits anymore for my aides because I don't have to. And so in that world, if the surveyor wants to go out to see the patient, how do I make that happen? And would it be possible, given the 1135 waivers, to say, look, if I don't have to supervise the aide in person, we can do this by remote video. We know the aide's out there. We'll call her iPhone, and you can talk to the patient through the iPhone. It takes care of verification, prevents patient exposure, helps to flatten the curve. We'll use their own concerns against them, because that's the reality of home health right now. And I don't know if those things have come up. The visits are, this whole survey process is kind of gearing back up. But those are some things to think through, because as we're going through this process, we're going to have thought this through in advance. Other rights that your staff and patients, the staff don't have to take calls from surveyors after hours or while with patients. I've had surveyors call staff members to quote, verify information after hours. I had one case where a surveyor called a nurse who was on her day off. She was at her house. She was working as an HVAC tech to get her air conditioner replaced. And the surveyor expected her to be able to answer questions about work with no reference off the top of her head. So our staff can feel free to say, you know, not right now. Same thing with our patients. Our staff don't have to answer questions over the phone. They don't have access to documents. They don't know who they're talking to. They have the right to say, you know, I'm happy to participate in the survey, but I need to know who I'm talking to, especially if we're going to talk about patients. If they're talking about just infection control, it's not a HIPAA issue, but it's still a question of, am I really talking to a surveyor? And I think those are things that, especially right now, when our staff is already on edge and already stressed, it's okay for the staff to say that and be upfront with the surveyor. Look, our staff, if they're off, because they're working hard, if they've got a day off, they're probably interested in taking your call. We've asked them to participate, but we'd ask that contact to go through you, and the staff might tell you to call us and arrange that visit or arrange that telephone conference, because we're probably not all going to get together and meet in person. So your staff should be aware that it's okay to say that. If they don't have to feel pressured, we obviously want them to participate and to talk to the surveyor. They don't have to feel pressured that you have to participate right now, that they have time off, and they can utilize that time off. And the patients have the same rights. They're always free to refuse a visit. They're always free to decline calls. The survey process shouldn't be stressful or burdensome to the patients. And I've actually had cases where we have complained about surveyors because the process was so stressful to the patient. I've had patients' family members write letters to state survey agencies about the survey process because it was so stressful. The surveyors are obligated to respect patient rights just as much as we are. And again, it's a bigger issue right now. Home health and hospice patients that we serve are much more at risk than the average folks. If they've got comorbidities, they're old, they have all the things we're worried about. And as such, they're more scared. And so they're far more likely, if they're not going to let us come into the home, if they're going to reject our nurses and our staff, they're going to reject the surveyors as well. And that's okay. They're okay to do that, and their fear of COVID is legitimate, and the surveyor needs to understand that, and our patients should understand that, and we should understand that if that's the patient's decision, it's okay to tell the surveyor no. And I've already kind of gone with the staff, right? The staff, they're free to refuse, they're free to decline calls. The staff needs to confirm a surveyor's identity. This is a HIPAA question. If somebody calls me and wants to tell about a patient or patient's care, I'm required under HIPAA. I would completely agree with the state surveyor. I can share patients' protected health information with a surveyor because they're part of a government healthcare enforcement agency. But I have an obligation to confirm to whom it is I'm speaking. Over the phone, I don't know who I'm talking to. If you're in person, if we're at the office and you show me your card and you've got some way to demonstrate you're with the state, fine. I have verified your identity. Now we're well within the exception. But if you just call me out of the blue, I don't know who you are. Maybe you're a surveyor. Maybe you're with the same group of folks that likes to call and ask me about my car warranty that needs to be renewed. I don't know, and I shouldn't share information about patients with them. If I come to the house and the surveyor just shows up, I shouldn't just let the surveyor enter. Again, there's a whole process for getting the patient's approval in advance. Staff shouldn't provide the surveyor with personal protective equipment. I've got mine, got a limited amount. The surveyor should bring their own. The surveyor doesn't have their own. As Arlene pointed out, they shouldn't come. We have a policy on this, right? We're in the midst of a public health emergency, and we should have a policy addressing how we're limiting staff and patient exposure, and we're acting as a gatekeeper. We should also note the HIPAA compliance angles, and there's also a wage and hour issue here because in some contexts, when the surveyors are approaching staff after hours, are we getting into work time issues, things like that? We clearly want our staff and patients to participate, but that during the public health emergency, we want more visits by telecommunication, want more interaction that way, and so our interaction with patients will decline, and that will impact the survey process as well. But having it all written out in advance gives us something to point to when the surveyors come in. And it can also, in the policy, talk about survey accuracy. If the survey goes beyond infection control, it's important that your staff can reference documents. If they're asking the staff about policies, your staff may have been trained on the policy, your staff may be following the policy, but we don't want to let our staff be set up with a gotcha moment where they're asked a question and they can't verbatim remember what the policy says. I've seen cases where what the staff member is quoted as saying, what the policy says, it's a difference in phrasing, but not might be materially different, but the surveyor cites it anyway. So we want to make sure that we're accurate. The policy should include the procedure for patients and staff to direct the surveyor to contact the agency to schedule visits and how that would work. And when the surveyor begins the survey, the agency administrator should explain our policy to the surveyor. Make sure they understand we're willing to cooperate, but we're trying to protect our staff and protect our patients. Because we're not trying to hide the ball. They might think that, but that's not it. So those are some thoughts from my end on preparation and the IJ and being ready for the IJ process, because we want to avoid it. But if we have one, we're going to have to move quickly. And with that, I think we'll spend the rest of the time taking questions.
We will, Bob, and thank you so much to you, Arlene, Lori, and Sharon for sharing all your expertise. And so I know we're right at the top of the hour from when we got started, but we're going to stay on the phone a little bit or the webinar a little bit longer. And I'm going to transition to Cindy so she can kind of have you all, while we have your ear and your expertise, to some questions that hopefully you'll be able to answer for our attendees today.
Thank you, Dee. And just as a reminder, if you have any questions you would like to ask, please type them directly into the Q&A box. And I'm happy to pass those along to our presenters. I've been keeping an eye on the box today. And so we have one question to start with here, and anyone is free to take this one. They haven't identified anyone specifically, but there was discussion about human resource related issues. Has CMS issued any specific guidance for human resources personnel files, like updating credentials, physical exam, TB test, CPR, and license renewal, et cetera, in light of the current situation?
Okay, so if one of you all is answering, it's a free-for-all. Just make sure you've unmuted yourself.
This is Arlene. Sharon, you might want to take this, but I guess my question is, are they asking, is CMS making an exception because of the pandemic? Or I'm not sure that I understand, because the personnel files have to be updated consistently. So
Basically, what you're saying, Arlene, is there hasn't been any change in what CMS expects to see in those files, correct?
no, that's correct. Yeah.
Okay.
And I think, Cindy, this is Lori. I think if anything, there's more of a focus on, the surveyors looking at us from a perspective of, our accrediting body, Joint Commission, even recommended that we do a survey, the HR survey our staff from a capacity and risk standpoint, and availability, flexibility, et cetera, to be able to show a surveyor how we are nimble and proactive in terms of caring for our patients for this in this pandemic. Because as we look at those two items, so for me, I feel like there's more of a focus on those personnel files and less forgiveness. I don't know how anybody else feels.
Well, Lori, we have, I think, two questions that are specifically directed toward you. That doesn't mean someone else can't contribute, but they're identifying you in both of them. The first one is you had a slide on one of your slides. You referenced the importance of how we identify and report COVID. Are there any specific resources available into how we should be collecting that information or performing those tasks so that it's very clear that we're on top of it?
I think there's no specific process, but every agency needs to develop their own way to flag it. In particular, if they accepted any stimulus money and they signed any attestations to that, you are also attesting to the fact that you are able to identify what COVID patients you've either cared for or presumed COVID. So it's twofold from the perspective of, we've got a patient. Was it first person exposure? Did we have to go to our public health and report that? And then also from the financial component of, did you attest to that you have them and that you're tracking them, and who are they and what did we do and what were the medications, how did we care for them? So I think everybody's got to develop their own strategy.
And kind of along those lines, it was very clear in today's presentation that we need to be survey ready. And a lot of it about being able to be organized and to have that information. And I think that's one thing when we're talking about binders or having meetings or, people that we can see. Do you have any best practice strategies or a couple of tips about how to try to be that ready when half or more of my office staff are working remotely? And where is this binder going to exist if we're not physically in the same place to update it?
Yeah, I love to talk about that. I wish that my administrator and copy director were on this call because they do such an excellent job. And while I was here listening and we have all been sharing, I was also getting updates. We utilize Smartsheet. And if you know it, then you'll know what I'm talking about. If you don't, then please go in and investigate it. But Smartsheet is an excellent way to remain organized. It assigns tasks. It gives dates in terms of completion. It's real time in terms of sharing. And every time something's updated, it'll alert whoever's on that sheet. You choose what members of the team are on the sheet, so you're not inundating people who don't need to be part of that particular project. And you can have the smart sheets based on projects. So I would say absolutely, it's great when you're in the office and you can hand a binder off to a surveyor. And when you can't and you're all scattered, I know our team is also on Skype all day long, so they're working that way too. But please go check out Smartsheets. I think it's an excellent way to organize for this situation.
So what you're suggesting is investigating, obviously, a HIPAA secure system for being able to share that kind of information and try to get away from the emailing the most recent copy of something. We all know how that works because we end up with 50 slightly different copies of the same thing, and somebody forgot to save it or saved the wrong one. And I can see where, okay, here's the surveyor and I'm giving them, here's what we're doing with infection control, and oops, I gave them the one from 2 weeks ago, not the one we updated 2 days ago. So I think that's a big piece of looking at how we use electronic tools to centralize this information so we're not risking giving outdated information or people not knowing where to find things. Because I think you made a great point, Lori, that if we look like we're fumbling, that usually sets us off on the wrong foot from the very beginning when it comes to survey.
Yeah, and you nailed it, Cindy. With the smart sheet, I can be working in it and I can save my update and immediately everybody can see what I've saved. So you can be working in it, I can be working in it. And the idea behind it is it's real time. So like you said, it's not like I email you and then, who's on first, you know what I mean? This is one document that we can all go into and be working on collectively. So it's much better. And I'm sure there's other solutions similar. That's just the one in particular we use.
Well, there's smart sheets that you mentioned. I have some people are using Google Sheets. Sync is another platform. I think there's really an issue of potential cost and accessibility, but I think that the point being that emailing multiple copies is probably a very risky way to have this pulled together. We have a question specifically for you, Sharon, about kind of the idea of I could get a telephone call survey. And Bob, I loved your point about how do I make sure that this is really the surveyor? I mean, it's sad to me, the stories already of people trying to take advantage of people with fake calls related to this pandemic, let alone it is my responsibility to make sure it's really a surveyor. But Sharon, is there a specific list of questions or a place our attendees could go to kind of how do I prepare for that kind of survey? Because we do, the mock things for when somebody shows up, but are there places I can go to find what those questions might be if we were going to do a mock telephone version?
Well, as I understand what's happening, most of the time when it's remote, they are actually calling to request documents. And there's not a lot of preamble to that unless they have questions about the documents. So we need to be able to satisfy them that they are speaking to someone like the administrator or someone in charge with authority to do it. And the client that I had most recently that had a remote survey this week, they sent the documents in. They heard back from the surveyor that she got them, and they haven't heard another word since. So I think some of this depends on the surveyors, but they're going to ask you about the degree to which staff has been educated. Do we have any documentation that shows that education? Can you send them the emergency preparedness program? Can you send them copies of the policies, et cetera, et cetera? So that seems to be mostly what they're doing when it's remote. One thing as long as I'm talking, one thing I want to add back on that human resources question, because I couldn't figure out how to get myself unmuted. One of the, CMS has not issued any waivers or any guidelines or anything else related to human resources. However, most of the state governors have. So last weekend, as I was researching waivers related to plans of care and whether or not NPs and certified nursing or nurse specialists and others could sign plans of care, I went and looked at all of those executive orders in all 50 states plus the District of Columbia. Most of them do have, they've elasticized the timelines around license renewals and other things like that. So for instance, if a nurse has a license that is expiring during the public health emergency, almost all of those deadlines have been waived, but it's being done at the state level, not the federal level.
Good point, Sharon, because there can be some variability there. So it'd be good to check what the rules are currently in the state you are in to make sure that you're using the most current rules that apply.
Correct.
Arlene, I have a question. You can kind of start this conversation. It's a variation on a theme that we're hearing not just in today's discussion, but in multiple webinars over the last several weeks, is if this is such a focus on infection control, how do I manage this? Do you have any suggestions for situations where access to PPE is part of the problem? I know what the recommendation is, but I either don't have enough or we're hearing reports of certain disciplines get access to the PPE, but I don't have enough for other disciplines. So I tell them a mask is sufficient. That's all you get. Any thoughts on trying to balance I want to be survey ready, but the reality is I don't always have all that PPE.
Wow, that's a really good question. It's a problem everybody's running into, I think. But I think that is loosening up a little bit. I know that I think it was Interim Healthcare, the home health, the franchised home health care company, they actually opened up and were having available all the PPE equipment on their website. And if somebody wants to email me if they need it, I can get that website to them. But I do know that for home health and hospice, they were offering to allow people to purchase from them. I think that one of the important things is that you have documentation that supports how well you try to research getting the PPE. I don't know if the rest of the panel here knows of a place to get it or how you would react. I think the documentation is going to be the most important thing to make sure that you document every time you try to get it and what kind of roadblocks you've run into and where you tried to purchase it. And I don't know, Sharon, Bob, or Lori, do you have any other ideas?
This is Lori. I'd love to help. First of all, I think folks need to get resourceful. I know that between our director of QAPI and our administrator, they reached out to our coalitions, and we received a lot of donated people. So if you're doing your job in terms of networking, you're going to have a much better chance of getting some donated PPE working for your coalition. Secondly, it's funny because I get an email today saying, hey, thanks for making the right call to our whole entire team on going to full PPE. And that included reusable face shields. So early on, we went to a woodworking company that was making face shields and purchased a face shield for every single employee. Surgical masks were easier to get. You could certainly put a surgical mask or, we wanted to use N95s, which we ended up getting the right amount. But even if you had to go with a surgical mask or a KN95, which is a little bit better under that full face, and then, you had the disposable mask to throw out, but the full face shield could be cleaned with alcohol. That's certainly a way to go. And if you need references for that, I have those. And while we're on this, one of the administrators just texted me and said, and also hospitals, they were also donating some additional PPE. So that was another resource. But if folks are still having problems, please reach out. We've got connections for gowns, face shields, N95s. I was helping some friends in New York even to, and Arlene actually was one of the people that helped us too. So between us all, we probably have good resources.
And go ahead, Bob.
I would just add to that I think it's really important that the efforts you made to document all of them, because you can't use what you can't get. I mean, we had issues in Indiana where the state got a bunch in, and then the county health departments were supposed to be the distributors within the counties, because the state health department said we can't handle it. So home health and hospice providers were calling the county health departments, and the county health departments were saying, we have no idea what you're talking about. It was a huge mess early on. And so I would tell clients, look, you've got to document the contacts, who you talked to, what you asked for, and then other places you looked. And I think Lori made a good point of looking at other places. Then the other thing, too, to consider is there's a lot of OSHA guidance and CDC guidance on things like how to properly reuse an N95 mask, how to decontaminate a mask. I think all those things, now they're ramping up production, and I think shortages are starting to come to an end. But if I'm in a position of not having enough, I was just reading this yesterday, I think it was a CDC or OSHA's website talked about for your staff having 5 masks, five N95 masks per staff person, one for Monday, one for Tuesday. They wear it. They put it back in a brown paper bag properly, then use the Tuesday one, because the the understanding was in 72 hours, the virus, et cetera, dies. And so you wait 5 days and you come back around and use that mask. There's a bunch of guidance on that where you could also look at, okay, we got some, and then here's how we're decontaminating and reusing it per CDC and OSHA guidelines, because whatever the surveyors may want to object to, if I'm following another regulatory body's guidance on that to help address the shortages, I don't think they can fault you for that. So it's important to show those steps, because those are part of the steps we could take. There may be other steps we can do with our staffing and things to limit the amount of PPE we need. We're trying to document all those things and consider these other options we've got that the CDC and OSHA have given us as ways to help alleviate the shortage.
And we're getting, several questions about, accessing the information you guys just talked about, and we've had several requests about the handout. The handout was originally sent to the email that was part of the registration, but we understand some things can get missed in the cyberspace. So we will be resending the handout along with the recorded version of today's content, which will have all the slides that you're seeing on the screen today, and their contact information is on there as well. So you will have what you need to have to reach out or to have this as reference. Which, Bob, this is going to bring me to our final question for today, because it's kind of a loaded one, but you touched on it in your presentation, and I think it hit a nerve, because we are seeing issues of staff very uncomfortable to the point of refusing to go into homes that are either COVID positive or presumed COVID, or very, very anxious about, even with the PPE, how am I supposed to do this? And then the flip side being patients that are refusing to let us out, or assisted livings refusing to let us out. What do you advise us? I mean, from an employer perspective, is there any sort of waiver or protection I have if I have staff people that are refusing to go? What should I do with that? And I know that could be a very lengthy conversation, but are there some key points I need to be aware of if I'm coming up against that with my staff?
So there's kind of two parts to that question, three really. There's the employee issue, there's the patient issue, and then there's the facility issue. So we'll start with the employees. And that's a recurring theme. A lot of employees don't want to be exposed. They don't want to go into homes. I've had some cases where staff have gone above and beyond in their efforts to prevent agencies from serving COVID patients. The first thing to remember is your employees have a right to a safe workplace under state and federal OSHA requirements. And then with that, they have a right to raise workplace safety concerns and to complain about workplace safety. That's all covered under OSHA. Similarly, when you have multiple employees together complaining as a group, they may be able to consider those to be a concerted action under the National Labor Relations Act, which would apply to you even if you don't have a union, and protects employees who have banded together to advocate or negotiate for improving their work conditions, in this case, workplace safety. So the first thing I would say to employers is, have you addressed workplace safety? Is this a workplace safety concern that we can address through policies, procedures? Are we following OSHA guidelines, et cetera? In which case, the first step is to say, look, it's education, right? We're healthcare professionals. This is a disease. This is a virus. This is how viruses work. It's not magic. You're not going to die because you went outside. And I'm not a clinician, so feel free to take that, with what I'd say, the grain of salt on the biology side of it. But sometimes it's educating the staff on this is how it works. This is how the safety equipment works. This is why you're safe. Here's what we've got for you. Here are our procedures we expect you to follow. If you follow these procedures, and here's OSHA and CDC and CMS all agreeing that this will keep you safe. At that point, we've addressed their workplace safety issues. Then it's a question of, are they simply disobeying our policies and procedures? Are they refusing to go to work? Are they absent when they should be at work? Are they calling in sick when they're not sick? Then you can start to consider potentially disciplining them. I've had some employers who they have some staff who aren't worried about serving COVID patients. They trust the equipment. They trust their process. As one nurse said to me, I know how to wash my hands and don and doff my safety gear. I'm not worried about it. those folks are then assigned to a specialty team that just serves the potential COVID patients. Depending where you are, that's not a realistic solution because, as one agency pointed out to me, most of our patients are potentially COVID patients. So you can, if you've addressed the OSHA concern, if you address those things, so it's now just a standard employee discipline process, you can then take steps to say, look, if you're not going to do your job, we'll have to discipline you. Practically, in the current environment, I know when I tell clients that, well, you could discipline the staff, you could fire the nurse, et cetera. That's not necessarily a great option because, as some of the nurses have said to employers, you can't replace me. You've got nobody else. So it's difficult, but you can take action against it. You can discipline them for not going out there. Some have just quit. They're happy to take the unemployment, and you can't really stop that. And the pandemic unemployment benefits are such that they're likely going to get them. Some are taking time off because they have family members to care for. They have kids at home, and those are separate, issues under the other new benefits we've got. But I think the important thing is to make sure that we're not retaliating against staff for raising legitimate workplace safety concerns, that we're addressing those concerns, educating them, and then proceeding on to disciplining them for not doing their job once we've eliminated that question. With patients, we're back to missed visits. And I think this could be a survey issue as well, because when they refuse the visit because they're afraid. And if you go back to the COPs require us, when patients are refusing care, to identify what's their root concern and try to help them get past that to accept the care. And so here, the root concern is our staff and the potential they're carrying COVID is a greater threat to the patient than going about the care. And so I've told clients I would document my efforts to educate the patient and the patient's family on our safety measures, our infection control procedures, what we're doing to keep them safe, and why, because of that, there's actually greater risk for them foregoing the care than refusing the visit. And document all that. And then if you can't get them to accept the visit, then the question is, do you discharge the patient? Can you suspend care? What can you do? Because I don't think we want to just ditch patients right now. They need us. But we can't also just like, all right, well, they said I can't come in, so that's that. I think we need to document our efforts to educate the patients to try to get in the door, and then document all that for survey purposes. And then with facilities, it's the same thing. Educate them. We're healthcare providers too. We're taking steps. We're doing these things. I've had clients that have done similar to what the nursing homes are doing now and say, look, these are our facility staff. They're only coming into your facility. We don't send them to patients' homes. We're trying to limit exposure just like you are. Try to work with the facility. I've had some facilities have offered, like for nursing homes that have hospice patients, I've had nursing homes say, we'll provide the care, just give us the plan of care. There's a problem there because to date, CMS has refused to waive the core services requirement, but part of me feels like if we at least can make sure the patient's getting care, that might be an acceptable alternative. Again, we can't just abandon the patient. We probably want to discharge the patient. And to one employer's point or one provider's point, you couldn't even get into the facility to do a discharge and revocation because you can't get into the facility at all. So you're in this kind of catch-22. For home health, that go into assisted livings, we've had the same issues come up, and it's the same concept. Educate them about what we're doing for infection control. Educate them about the potential harm to the patient if we don't come in. Educate them to why we don't think it's a risk, and then try to find workarounds. And if not, look at, do we have to discharge the patient because we can't see them, or can we? CMS hates the phrase "place the patient on hold." They won't really place it on hold. We're just documenting repeated missed visits because we can't get in. That probably becomes a discharge as well, because of the risk on the other side of not seeing a patient. So there's a lot of this comes back to education, because I think what's happened in a lot of places is the fear of the disease from all the news reporting and all the gloom and doom has overtaken the facts. So when I see nurses who are saying, I'm not going to go out there because I'm afraid I'm going to get it, and you think, the nursing supervisor is like, well, the nurses understand how the virus works, how protected. We've done this with how many other diseases. This is the first time I've seen clients are going to homes where patients have flu or other infectious disease, and now they're suddenly acting like the protective equipment doesn't help them. And so there's that fear element. I think the education is your most important component to overcoming it, to get your staff, your facilities on board with all the things you're doing to keep them safe, and then, if necessary, proceeding accordingly after that.
Well, and I think that that kind of brings us to a conclusion today, because a lot of this has to do with education, whether we're educating our staff to be survey ready, educating our patients about the how we're managing their risk and the importance of healthcare, educating facilities, educating ourselves with resources and tools. And so we want to thank all four of our presenters and our host, Dee Cornetti, for pulling this together today. We know that everybody has a full plate and is very busy, so we hope that this information has been helpful to you. As we said earlier, a recording will be sent to you to share with additional folks as you see fit, and we'll include the handout again for those of you who didn't receive it initially, so that you have the information that you need. So with that, we're going to be adjourning today. We hope everyone has as safe and restful a weekend as possible. And we wish you nothing but as much peace as you can muster during these difficult and challenging times.
Thanks, Cindy. Thanks, Dee. Thanks, everybody.
Thanks. Bye.